One, we can start, sir.
Yeah.
Okay.
Good evening, doctors. Vikas from Bayer Oncology. Thank you for joining today's discussion on prostate cancer. Today we have Dr. Yugandhar Sharma, sir. Sir is a senior consultant radiation oncologist from Renova Soumya Cancer Center. Sir is having a vast 20 years of experience in the field of oncology. So, over to you, Dr. Yugandhar, sir.
Good evening, everyone. Today's agenda is about the prostate cancer, especially concentrating on metastatic hormone-sensitive prostate cancer. To set the things going, I will be speaking upon the recent evidence of chemotherapy and the treatments in metastatic hormone-sensitive prostate cancer. And Dr. Shravan will be discussing on another aspect of managing metastatic hormone-sensitive prostate cancer. And Dr. Sanath will be presenting some cases, and followed by we'll be having a Q&A session, and we three will be discussing few real-world scenarios. And after that, we conclude the meeting. So, can I share my screen?
Yes, sir. Please.
Just a minute. Yeah, are you able to see my screen?
Yes, sir.
Okay. So, sorry. So I'll be speaking on reaching new heights in prostate cancer, metastatic hormone sensitive prostate cancer. Am I audible to everyone?
Sir, you are audible. Sir.
Okay. So, going to the topic, I disclose that this is sponsored by Bayer. So, as we know, prostate cancer has a long clinical course. It goes on from localized prostate cancer to a locally advanced prostate cancer, and without even metastasizing, having an initial biochemical recurrences, wherein the most common form of treatment, even in the real world data, if we see, most of the patients are being treated with ADT alone. The next stage proceeds on to probably a primary progressive metastatic hormone sensitive prostate cancer or a non-metastatic castration resistant prostate cancer. So ADT is the backbone of treatment for prostate cancer, as this is hormone dependent, and most of the patients die with prostate cancer or because of prostate cancer, and everyone almost who dies with prostate cancer are in the castrate resistant stage of prostate cancer, most 90% of the times. Most of the treatments which are directed towards metastatic castrate resistant prostate cancer has shown only OS improvement of only around 2.5 to 4.5 months, which is pretty dismal, which when we compare with other clinically long course diseases. So, what we can do here, we should prevent prostate cancer going to be castrate resistance, and there is a large scope of improvement when we can treat it at a stage where the hormone sensitivity is preserved. So, in this context, if you go back and look, there are quite a few trials which have shown that ADT alone is not sufficient in treating hormone sensitive prostate cancer which is metastatic. Especially the Stampede trial, the arm C and arm E, you can see with ADT alone the FFS is around 11.2 months, and the overall survival is 42.1 months. So this is basically the 11.2 months is the timeline where the patient lands up in castration resistance with ADT alone, and this has been proven in multiple trials where ADT alone was given or ADT with placebo has been given, that the castration resistance takes over in less than 14 months time. So that is the reason in the clinic we tend to speak with the patients or counsel with the patients that ADT alone is not sufficient. I think this is a purely oncology point of view. So we can do much better right now. Especially in Stampede, they also tried giving prostate radiotherapy in metastatic hormone-sensitive prostate cancer, but this was only fruitful in patients who have less than 4 bone metastasis, which is typically considered as low volume disease. I'll come to the definitions later on. But in high volume disease where there are greater than or equal to 4 bone metastases, the improvement with prostate only radiotherapy was not so significant. Especially if you see, the prostate radiotherapy was also given in 2 types of schedules in this Stampede arm. The patients who received docetaxel plus ADT but not in the control arm. So patients who received docetaxel plus ADT in low volume metastasis, they showed a significant failure-free survival and OS benefit. And the radiotherapy given was 55 gray in 20 fractions or a schedule of 6 gray once in a week for 6 weeks. So if you see the outcomes, there has been a constant wealth of data that has been generated for the past around 13 to 15 years in the systemic therapy and with the advent of ARPIs. So if you see from 2013, the GETUBE trial which has shown docetaxel alone versus placebo, the standard of care has changed. Before Stampede, the charted and GETUBE trials have shown that docetaxel has provided a survival benefit. The Stampede took forward, and the latitude, until enzamet, it was comparison with the standard arm. Standard arm showing only ADT. ADT was compared with either docetaxel plus ADT or abiraterone or enzalutamide or apalutamide. Or enzalutamide versus non-steroidal anti-androgens. So everything has showed rather than single treatment, a doublet treatment will help in improving the survival of patients. If you go forward and see the charted docetaxel in metastatic hormone-sensitive prostate cancer, OS improvement is around 16.8 months. But in low volume disease, the hazard ratio has crossed 1 and there is absolutely no improvement in OS. And in latitude trial, you can see the abiraterone in high risk metastatic hormone sensitive prostate cancer, there is absolute improvement in the overall survival. And if you can see this, the prostate specific PSA progression, it is in the placebo group, in the ADT arm, it was only 7.4 months. In 7.4 months, the patients achieved castration resistance, and further subsequent therapies, if you can see, if they achieved prostate PSA progression or achieved castration resistance at 7.4 months, subsequent prostate cancer therapy was given at 21.2 months. That means the placebo arm somehow was not treated properly. But still, if you can see the difference, the castration resistance here in the abiraterone arm was around 33.3 months and the subsequent cancer therapy was at 54.4 or 54.9 months. Everything was clinically very significant. And the main drawback of this using abiraterone was the toxicity. Even with low 5 mg, normally we prescribe around 10 mg, but nowadays we prescribe 5 mg also. In the long term is because these are hormone sensitive metastatic prostate cancer. We should understand that in the metastatic prostate cancer, there is no hard and fast rule where we should stop the therapy. The standard textbook guideline is till disease progression. If you see that till disease progression, these patients tend to have lot of complications, especially in the clinic. We are very much concerned about the metabolic disorders that is caused by abiraterone in combination with prednisolone, especially hypertension, heart related issues, hypokalemia, and liver function abnormalities. The other trial trying another ARPA was apalutamide in the Titan trial, which somehow has showed both in high volume and low volume disease there was significant survival benefit. And in the Enzamet trial, again high volume and low volume both showed a significant survival benefit. But there is a controversy where in which patients in which patients we can intensify the therapy to further improve the outcomes. In that direction, there were few trials which were done, and the most important ones are the Peace 1 and the Latitude and the Arasens trial. In the Peace 1 study, the design was they took de novo metastatic disease. All the other trials, they had certain limitations in the inclusion criteria. Some patients had started ADT quite long ago. Some patients have started ADT when inside the trial. Some crossed over. But in this Peace 1 study, there were de novo M1 disease, and within less than 3 months of ADT prior to randomization, and no prior cytotoxic chemotherapy or any other usage of biological therapies. This is a 2x2 factorial design, wherein standard of care at the start of the trial standard of care was ADT, but during the trial, when the trial was started and it has included, during the trial it has amended to standard of care is ADT plus docetaxel. So in addition to the standard of care, they used abiraterone or abiraterone plus radiotherapy. So here we have to understand what is high volume disease and what is low volume disease. According to the charted definition, you can see any visceral disease, any extrapelvic lymphadenopathy more than 2 centimeters, any more than 4 bone metastasis outside or any one bone metastasis outside the pelvis and the vertebra. This is called high volume disease. And if you see another definition of Latitude trial, any 2 risk factors which include Gleason score of 8 or higher and any visceral metastasis, another one is there which I forgot, but yeah, those are called high volume diseases. So in this high volume diseases, you can see there is clear cut benefit in the OS. The median overall survival is 5.1 years when compared to standard arm, where it is only 3.5 years. But in low volume disease, it failed to show any significant benefit in terms of overall survival. So this led to the confirmation that in high volume disease, you can improve outcomes by adding abiraterone to docetaxel versus docetaxel alone. That means a triplet therapy is going to work better in terms of overall survival. But in low volume disease, it is not as beneficial as high volume disease. So here, selecting a patient with high volume disease is very important. But as we know, in a metastatic setting, as I previously told, there is no timeline where we are going to stop therapy. So this has to go on for a long time. And we know the concerns with abiraterone plus prednisolone. So in view of that, we are going to see the Arasens study. So this is a randomized double-blind placebo-controlled phase 3 study. As you can see, the inclusion criteria, it was the ECOG PS should be less than or equal to 1. So most of the patients in this study were ECOG PS 0, and all are de novo metastatic hormone sensitive prostate cancer, and they should be candidates for ADT and docetaxel. So this is the most important point. The performance status and they should be physically fit to receive treatment. And the stratification is based on M1A versus M1B versus M1C, and almost 90% of the patients they received docetaxel 6 cycles, and the first visit was in 2016, and last patient first visit was in June 2018. Total of 1300 patients, equally distributed, and the primary endpoint is the overall survival. And there are a lot of secondary endpoints they studied, and post the first publication they have also did a subgroup analysis in terms of high risk high volume, low risk high volume, and low risk low volume disease, and like this in these different subgroup sets also they did a analysis about survival. So you remember these secondary endpoints. These are very important in determining how the patient is going to behave during the study or during the clinical course of the patient. So 87%, almost 90% received all 6 cycles of docetaxel, and adverse events between the two arms were almost identical. This is the most important point. So, and most of the adverse events were attributed to docetaxel. Once the docetaxel has completed after 6 cycles of docetaxel, most of the patients recovered from almost all the side effects of docetaxel. You can see on the overall population, there is an absolute risk reduction of 32%. HR hazard ratio is 0.68. There is absolute risk reduction of 32%. You can see, and there is 63% overall survival at the end of 51 months of since randomization. And benefit is seen in all subgroup, especially high risk and low risk patients. You don't get confused with high risk, low risk, high volume, low volume. High risk is basically depends upon the Gleason score, PSA levels, as we stratify according to the NCCN guidelines. High volume disease and low volume disease is according to the charted and the latitude definitions. So a patient in common, irrespective of the risk, volume, high volume disease, either it is high risk patient or low risk patients, there is absolute benefit and risk reduction in all the subgroups. If the patient has low volume disease, it is not yet clear. So the key secondary efficacy endpoints are time to castration resistance. As you can see, the curves separate significantly at the end of around 60 months. There is 64% risk reduction, and the time to first subsequent anti-neoplastic therapy, again 61% risk reduction, and time to pain progression and time to first symptomatic skeletal events, 29% and 21%. So in almost every secondary efficacy endpoints also, this trial has shown that triplet therapy without any increase in adverse events, there is proven efficacy. Especially there is also a doubt that how does the PSA response quantify here. So as we all know, achieving a deep and reliable PSA response is very important in explaining the prognosis to the patient. So in this patients, in this study, in these patients, most of the patients on darolutamide achieved a deeper PSA response at 36 weeks. So within 6 months, the patients had a very deep PSA response of less than 0.2. The patients who had more than detectable PSA at 36 weeks, as you can see, the hazard ratio is 0.23. That means that there is a highly significant meaningful clinical benefit if we are able to achieve a deep PSA response. And even the overall survival also, you can see the median was not yet achieved, but here the median is 30 33.3 months. And if you go into the subgroup of high volume disease, it is still significant. The hazard ratio becomes zero point 0.2, and the darolutamide triplet achieved long periods of no disease progression and also significant improvements to overall survival. And in low volume, again, here also the time to PSA progression was highly significant in low volume disease also. But here we have to take this one with a pinch of salt, because almost 80% of the patients in this study were having high volume, high risk disease. Very few patients, almost around 8% or 9% patients had low volume disease. Even then, this was significant. So, how do we decide between a doublet and triplet therapy in metastatic hormone sensitive prostate cancer? So, most important thing is when the patient sits in the clinic with us, we have to assess the physical status of the patient, whether he is able to tolerate the treatment, or whether he is he going to accept the docetaxel toxicity. And if you go into the deep analysis of this study, you see the median age is around 67 to 68 years. So that makes this study very successful, because most of the patients receive docetaxel. And the extent of disease, I would prefer a triplet therapy in a high risk, high volume situation, and targeting all the clones at once and decreasing the likelihood of getting a hormone insensitive clone. And when the age and life expectancy is more than 6 to 10 years, so you hit it hard early, because prostate cancer on progression, as we see, most of the prostate cancer patients die due to complications of castration resistant prostate cancer. Though it might not be attributed, we all know the truth. And yeah, docetaxel is going to be an obligation in near future. And as you can see, this combination of triplet or docetaxel post ARPA progression is much less effective and more toxic, and patient needs to be informed about the options of treatment. I stop here, and I'll take the questions later on. Is Shravan ready?
Yes, sir. Ready.
Okay. Okay.
Sanjit, will somebody share slides from your end if possible?
Yeah. Shravan is going to speak on error note evidence.
Shravan, sir?
Yes, Sanjit. Can you share slides from your end if possible?
Yeah, give me a minute, sir. Then 1 minute, sir.
Sure. Yeah.
Sir, I will be sharing the screen. So just tell me, sir, whenever the slide should be changed. So I am on mute mode.
Sure.
Okay.
Okay. Shall I start, Sandeep?
Sir, you can start this.
Can you put the slides in slide mode? Yeah, now I can see. I hope slides are visible to everybody.
Yes, Shravan. Yes, Shravan, I'm able to see that.
Sure. Thank you. So, good evening, everyone. Thank you, Bayer Pharma and Sandeep, for this opportunity. I think Sharma sir has nicely elucidated the treatment armamentarium of the metastatic HSPC with respect to the various lines, evidence behind it. So, my job, sir, made bit easy. So, now I am restricted my talk to this specific trial, that is RNOT. So, basically, role of darolutamide along with the combination of ADT without chemotherapy. So this is a trial basis for this RNOT study. Slides are provided by the Bayer Pharma. Next slide. So these are my disclosures. So this is a so uh, treatment horizon, how the evolution of various systemic therapy agents have come into the treatment of metastatic hormone sensitive prostate cancers. So before this, there is only castration. So that was in the era of 17th century. So in the 17th century, it was only castration, followed by almost two centuries till 1900. It is then we have the androgen therapy from 1900 to till 2014. So there were no much improvements in management metastatic hormone sensitive prostate cancer, except for the castration and ADT and diethylstilbestrol. There were no much improvements. So in 2000s, early 2014, so we have the chatted data. So this is a combination of docetaxel along with androgen deprivation therapy. Then in 2017, we have the abiraterone along with combination of IDT from the data of latitude study. And in later part of 2019, we have new kid in the block, that is enzalutamide. As per the data from Archis, the combination of enzalutamide plus ADT. Then the in 2019, there is another ARPA, that is apalutamide, as discussed earlier from the Titan study, along with combination of ADT. From there, the treatment landscape has changed from ADT plus ADT plus docetaxel or ARPI to the combination of three modalities, that is called triplet regimens. Based on the data, that is first data of the triplet regimen is piece 1 data, combination of abiraterone plus ADT plus minus docetaxel with or without RT in 2021. And in the later part of 2022, we got another triple data from RSNs, as discussed just now, darolutamide along with combination of ADT plus docetaxel. Now, in 2024, the two data with respect to the doublet from darolutamide, that is Nubeca, so that is combination of ADT plus darolutamide in RSEC, which is a phase 2 data from US population. But later, now we have phase 3 data in form of Aranode, the combination of darolutamide plus ADT. So this I am going to discuss in detail. So despite the treatment with the androgen receptor pathway inhibitors, that is ARPI, along with ADT or docetaxel plus ADT, still a larger chunk of patients with metastatic HSPC may progress to metastatic CRPC approximately 6 months from the start of treatment. So why this study is important is, from the latitude or Archie's enzyme data, we have potential ARPS are including apalutamide from the data and data. But what unique from Aranode study is because apalutamide is own side effect profile. Patients who are elderly patients, diabetic, use poorly controlled diabetes. So the patients we not give steroid when we have to give apalutamide, or if the patient is having some baseline CNS disorder, seizures, enzalutamide may be the contraindication. So, in order to overcome these side effect profile, now we have a newer ARPI into the therapeutic armamentarium, that is darolutamide. So, this important drug in management of metastatic HSPC patients, especially if the patient is having uncontrolled comorbidities, either metabolic or CNS related adverse events. Next slide, please. So this is an unmet therapeutic need, as I mentioned earlier. So though we have a plethora of ARPIs in the treatment armamentarium, but what makes a molecule or a newer androgen receptor pathway inhibitor molecule makes unique from other molecules is basically, apart from the efficacy, it is a safety profile associated with the molecule. So whenever the patient is having a lot of polypharmacy because of the comorbidities already existing in addition to the prostate problem, so we need to have a drug which can have a favorable safety profile, also have a least possible minimal drug-drug interactions. So as mentioned earlier, RSN phase 3 data along with combination of those factors already showed a beneficial efficacy safety profile in patients of metastatic SPC. It led to the approval in our country in 2023. So this is a data of phase 3 Aranode study, that is combination along with ADT, which provide better efficacy benefit, also have a favorable safety profile in patients of metastatic HSPC. Next slide, please. And this is a darolutamide molecule without usage of docetaxel, unlike the data of Arasens. So this is a background of this study. Darolutamide plus AD with docetaxel is a standard of care for metastatic HSPC. In Arasens, we have already known that triplet regimen has benefited both with respect to the efficacy as well as safety. And Aranode was mainly designed to evaluate the combination of darolutamide plus ADT versus ADT to provide a newer treatment option for patients of metastatic HSPC without any usage of docetaxel. So it's a purely doublet with a darolutamide combination along with ADT. Next slide. So this is a randomized double-blind placebo-controlled phase 3 study. So the patients included were around 665 patients, metastatic hormone-sensitive prostate cancer, either histologically or cytologically confirmed adenocarcinoma of the prostate. ECOG PS up to 2 were included in this study. Stratification factors being visceral metastasis and whether the prior local therapy received yes or no. So this is a 2:1 randomization into darolutamide 600 milligrams twice daily along with combination of ADT versus placebo plus ADT combination. So the primary endpoint being radiographic progression-free survival, and there are number of secondary endpoints which include overall survival, time to pain progression, time to PSA progression, time to CRPC, time to initiation of subsequent anti-neoplastic therapy, and also the safety profile. And you have other pre-specified endpoints also. So initially it was open label darolutamide inclusion. Later, 100% of the patients was crossed over to open label, even from the placebo group also. So the median follow-up of for this study was in patients who are received darolutamide was 25.3 months, whereas placebo group was 25 months. And selected endpoints includes overall survival and safety. Next slide. So this is a baseline patient demographic clinical characteristics. Median age 70 years. So when it comes to the racial representation in this study, this is one study where we have a good Asian representation. You see the patients, around more than 50% of patients were there, but almost third of the patients were Asian ethnicity. And peacock performance status, most of the patients, like more than 50%, were peacock 0, and 1 to 2 ECOG were around 47% of the patient, and both are well matched in study as well as in the control arm also. Median PSA was around 21 in both the arms. Gleason score, that is then 8 at baseline diagnosis, was around 70% in both the arms. And this is a high volume disease distribution versus low volume distribution was fairly balanced. Most of the patients, all 20% of the patients were high volume patients in both the arms. And visceral metastasis were around 12% in the darolutamide arm compared to the same in placebo group. So with respect to the demographics and clinical characteristics, age, ethnicity, performance status, Gleason score, PSA, metastasis, including visceral metastasis and low volume, high volume. So they are well matched in both the arms of the study group. Next slide. So as just now I mentioned, so there is a good representation from the Asia Pacific region. Around 33% of the patients were Asian ethnicity. Rest all are white and other ethnic groups. Next slide. So coming to the efficacy analysis, so darolutamide plus ADT, you can see from this Kaplan-Meier curve. So the radiographic progression-free survival, that is primary endpoint, the median was not reached, whereas the median was around 25 months in placebo plus ADT arm with a hazard ratio of 0.54. So there is a reduced risk of radiological progression or death by around 46% when compared to the placebo plus ADT. And median follow-up of around 25.3 months in the darolutamide group compared to 25 months in the placebo group. So the primary endpoint was met, that is improvement in RPFS in darolutamide plus ADT arm compared to the placebo plus ADT arm. Next slide. So this is a subgroup analysis with respect to the primary endpoint, that is RPFS. So all the subgroup analysis starting from the age, baseline PSA, whether it is less than median versus more than or equal to median, PS whether it is 0 versus more than or equal to 1, Gleason score whether it is less than 8 versus more than or equal to 8, high volume versus low volume, and different racial ethnicity, geographic region, whether a visual is present, yes or no. So all the patients have benefited with the darolutamide plus ADT arm compared to the placebo and ADT arm, and including patients of both high volume and as well as the low volume disease patients were benefited with this newer ARPA, that is darolutamide, as we have discussed the definition for high and low volume. So coming to the secondary endpoints, so we have 5 key secondary endpoints. So the main ones, the time to pain progression. So the time to pain progression was better in a darolutamide ADT arm compared to the placebo plus ADT arm with a hazard ratio of, in this you can see 0.72. whereas the other secondary endpoint being time to PSA progression also. So here in this darolutamide placebo, darolutamide plus ADT arm, the time to PSA progression median was not reached, whereas it was around it was around 48 in placebo plus ADT arm with a hazard ratio of 0.31 and time to metastatic CRPC. So the median was not reached in darolutamide arm compared to the placebo arm. And even the time to initiation of subsequent systemic therapy for prostate cancer, the median was not reached in darolutamide arm compared to the placebo arm, and the hazard ratio of 0.44. And the other fifth secondary endpoint, that is oral survival, the median overall survival with the darolutamide plus ADT arm was not reached uh, compared to the placebo arm with a hazard ratio of 0.81. So across the secondary endpoints of all these five, the darolutamide arm has favored over placebo arm. But this is a at the time of primary analysis, the OS data is immature. Since OS is immature, the patient needs to be followed up for the final survival data analysis. And all remaining protocol placebo patients offered crossover to darolutamide after the primary analysis. So this crossover was allowed in the placebo group. So as I mentioned in the previous slide, with respect to the secondary endpoints, the time to metastatic CRPC, time to pain progression, the median was not reached in darolutamide plus ADT arm compared to the placebo plus ADT arm. So here you can see time to pain progression, the hazard ratio was 0.72. So there is a 28% decrease in the time to pain progression in the darolutamide arm plus ADT compared to the placebo plus ADT arm. And even in time to metastatic CRPC was also compared to the placebo plus ADT. The median was around 13.8 months in the placebo plus ADT, whereas the median was not reached in the darolutamide plus ADT arm with a hazard ratio of 0.4. So there is a 60% decrease in the progression to the metastatic CRPC. So this slide highlights it darolutamide plus ADT has a significant role in delay in time to pain progression, as well as delay in time to progression of pain, as well as metastatic CRPC. And the other secondary endpoint, that is time to PSA progression. So here you can see from this Kaplan-Meier curve, when compared to the placebo plus ADT, the median was around 16.8 months in the placebo plus ADT, compared to the median was not reached in darolutamide plus ADT arm with a hazard ratio of 0.31. So there is a 69% reduction in PSA time to PSA progression. And the undetectable PSA level, or the PSA less than 0.2 nanogram per ml at any time during treatment. So you can see in darolutamide plus ADT arm, the undetectable or PSA less than 0.2 nanogram per ml was around 62.6% compared to 18.5% in the placebo plus ADT arm. So there is a significant response with respect to the PSA decline when compared to the placebo plus ADT alone. So this is a subgroup analysis where the PSA reduction, that is undetectable PSA or less than 0.2 nanogram per ml with darolutamide versus placebo in both high volume and low volume subgroups. So you can see from the left side of the cartoon, in a high volume subgroup at 24 weeks, that is 6 months of duration, the placebo group has showed around 10.8% compared to 44 in the darolutamide plus ADT. Even at the 36 weeks also, it was higher decline in PSA population proportion compared to the placebo plus ADT. That is around 47.7 in the darolutamide plus ADT compared to 12% in the placebo plus ADT population. Even at 48 weeks also, that is even at the end of 1 year, around 50% of the patients have achieved undetectable PSA in darolutamide plus ADT arm compared to around 14% in the placebo plus ADT. And in high volume, if you see at any point of this time, study of this study, around 15.5% of the patients were undetectable PSA in placebo, whereas around 54% of the patients have undetectable PSA at any point in darolutamide plus ADT. The same also, the benefit was also seen in low volume. But if you compare the graphs of high volume versus low volume, as expected, the darolutamide plus ADT has showed higher number of proportion of patients, those who attain undetectable PSA in low volume. So at the end of 6 weeks, around 72% approximately were undetectable PSA compared to 17% in the placebo plus ADT. And even at 36 weeks, that is 9 months also, more than 75% of the patients have undetectable PSA compared to placebo, which is only 20% hardly. Even at the end of 48 weeks, that is at the end of 1 year also, approximately 80% of the patients have the undetectable PSA in darolutamide ADT compared to 20% in the placebo plus ADT. And if you see any point of time in low volume group of patients, ADT plus docetaxel plus ADT plus darolutamide has around 80% of the patients have undetectable PSA compared to 25% in the placebo plus ADT. So the take home message from this slide is both high volume and low volume patients have undetectable PSA or PSA less than 0.2 nanogram per ml. Respective timelines are also at any point of time, the undetectable PSA proportion was higher when compared to the placebo plus ADT. And we also just discussed those patients who attain this mark, they tend to have a long-term durable response also. So we need to hit these patients early with try to attain a deeper PSA response and try to maintain the same PSA response so that we can improve the radiographic progression-free survival and ultimately overall survival also. Next slide. So this is a subsequent life prolonging anti-cancer therapy, the fifth secondary endpoint. So you can see from the darolutamide plus ADT compared to placebo ADT, the percentage of patients who would require the time to initiation of second anti-neoplastic therapy around 32% in study arm, that is darolutamide arm, compared to 28%, compared to 42% in the placebo plus ADT arm. And the if at all we need to initiate the second anti-neoplastic therapy, so most of the patients were received docetaxel first, followed by the abiraterone acetate, followed by enzalutamide and apalutamide, cabazitaxel in 1% of the patient, and less than 1% being the PARP inhibitor, that is olaparib. So most of the patients who were initiated were on chemotherapy, that is docetaxel, post progression on this ARPI or placebo. Next slide, please. So after knowing the efficacy endpoints, that is RPFS and 5 key secondary endpoints, now we'll delve into the safety profile of darolutamide plus ADT compared to the placebo plus ADT. So if you see the treatment emergent adverse events, more or less comparable, the grade 1 and grade 2 were comparable more or less in both darolutamide ADT plus placebo plus ADT arms. So any grade adverse events were around 90% in darolutamide ADT compared to the same in placebo plus ADT. Even grade 3, grade 4 adverse events, grade 5 adverse events are also more or less similar in both the arms. One important thing is treatment emergent adverse events which were led to the permanent discontinuation of darolutamide versus placebo. So around 6% in the darolutamide arm compared to the placebo, which is around 9%. So there is a higher treatment emergent adverse events which led to the permanent discontinuation were more in placebo compared to the study arm drug, that is darolutamide. And median treatment duration was around 24 months in darolutamide arm compared to the 17% in the placebo arm when the safety analysis was done. Safety profile of darolutamide in ARANOTE was independent of PSA response, and it is consistent with the favorable safety profile as we have seen in ARAMIS and ARASENS data. So now these are the most common adverse events which were defined as occurring at least in more than or equal to 5% of the patients in either group, that is darolutamide plus ADT compared to placebo plus ADT. So the most common adverse events reported was anemia. So the grade 3, grade 4 anemia was around 3% in darolutamide arm compared to 3.6 in the placebo group. And other common adverse events which were like arthralgias in order of priority, anemia followed by arthralgia, then urinary tract infections. So the grade 3, grade 4 was around less than 2% in the darolutamide arm compared to 0.5% in the placebo. Back pain, increased AST, ALT, that is transaminitis, GA related side effects, hot flushes. So these are more or less equal, more or less similar in both the arms, except one adverse event, that is fatigue. So the most common adverse event whenever we start patients on ADT plus ARPA, fatigue. So if you see in this comparative analysis, fatigue was less in the darolutamide ADT compared to placebo plus ADT. So around 5.6% of the patients were developed the fatigue, whereas it is more in placebo plus ADT, that is 8%. But rest of the adverse events slightly, some are high in darolutamide plus ADT compared to placebo plus ADT. Next slide. So these are the commonly associated adverse events with ARPA. More or less, they are also similar between the treatment groups. So the main adverse events like the cardiovascular side effects, arrhythmias, coronary artery disease, or diabetes, hypertension, metabolic disorders, hyperglycemia, and the cerebrovascular events, heart, including heart failure, falls. So these are more or less comparable in both the arms, that is placebo ADT versus darolutamide plus ADT. So with respect to the safety profile, it is safe when compared to other ARPS. And this is a analysis with respect to the health related quality of life, how the darolutamide has favored over placebo plus ADT. So you can see from this Kaplan-Meier analysis, time to deterioration in functional assessment of chronic therapy, uh, total score around uh, total score. So you can see from this analysis, darolutamide ADT, the median was around 16.6 months, whereas in placebo plus ADT, it is only 11.5 months with a significant hazard ratio of 0.76. So from this health related quality of analysis, now we can say darolutamide has extended median time to deterioration in FACT-P total score by around 5.1 months compared to placebo. And it is a first and only androgen receptor pathway inhibitor to demonstrate clinically meaningful delays in pain progression as well as the overall well-being. So this is from ASCO 2025. So again, the health related quality of analysis with respect to the social well-being and functional well-being and urinary symptoms. So all three domains were favored with respect to darolutamide plus ADT arm compared to the placebo plus ADT arm. So it's not just time to pain progression, but social well-being, functional well-being, urinary tract infection, and time to pain progression. All these were favored with respect to the darolutamide plus ADT. So now to conclude from this data, darolutamide plus ADT, that is from this ADROT study, which has significantly improved its primary endpoint, that is radiographic progression-free survival in a patient of metastatic HSPC. It also showed consistent benefit across all the secondary endpoints that we have discussed. And it also associated with a deep PSA response regardless of the baseline PSA levels. And it is the only first and only androgen receptor pathway inhibitor to demonstrate clinically meaningful delay in pain progression and other health related quality of indices like social, functional, and urinary tract related symptoms. And as per the safety term, reasonably favorable safety profile when compared to other ARPS like abiraterone and enzalutamide. However, with a caveat of cross-trial comparison. So now this is one of the important regimen, that is darolutamide plus ADT, even without docetaxel also a potential standard of care in managing patients of metastatic hormone sensitive prostate cancer. So with this, I conclude. Thank you. If any questions, we'll take it in the later part of the discussion.
Thank you, Dr. Shravan. Now I request Dr. Sanath, who is a consultant medical oncologist at Basavatarakam Hospital, to start the presentation.
So I think my slides are visible and I am audible.
Yes, you are audible, Sanath.
Okay, thank you, sir. So I would
Sir,
like
we
to
can't hear you. Anand sir.
just a second.
Yeah. Yes, sir.
Now, can you hear me?
Yeah, we can hear you, sir.
Okay, sure. So I would like to thank Bayer team for providing me this opportunity. Also, Sandeep. So now I will discuss a real world case. So before this case, actually, prostate cancer is a if you see discuss prostate cancer is little different from other cancers because prostate cancer usually occurs in geriatric patients. So definitely in all cancers we have to do complete comprehensive geriatric assessment. But in prostate cancer, definitely because prostate cancer is most of the times it's a case of it's a cancer of geriatrics or old age. So we along with cancer we have to deal the comorbidities, we have to deal with the drug interactions and social family support, frailty, and his vision, hearing. So these all his psychological nature. So these all we have to discuss along with the geriatrics and finances. So this is about a real world case. This is my case only. This is a real case. And patient was 68-year-old male without any comorbidities. He was fit. When he came, his PS was 1. He's presented with LUTS, lower urinary tract symptoms for 6 months. General examination, his vitals were stable. Per examination normal. PR I did not do. Urologist has done. Hard nodular prostate was enlarged with extra prostatic extension. Ultrasound abdomen was done. Grade 1 prostatomegaly with enlarged multiple nodes. So multiple abdominal nodes are also there. So MRI abdomen and pelvis was done. There is mass in the peripheral zone. So as we know, prostate cancer arises from the peripheral zone, not from the central zone. Multiple enlarged nodes are there, and bone scan showed multiple bone mets. PSA was 1680, and prostate core biopsy adenocarcinoma acinar type, and Gleason score was 7, 4 plus 3, and grade group 3 involves 90% of the tissue submitted. PNA is identified. So, and because of LUTS, he underwent channel TURP. Along with that, he underwent bilateral orchiectomy. So, we all know regarding the orchiectomy, medical, surgical. So, if you see surgical, I prefer it is one of the cheap and best methods because it is permanent one, cheap. And if you see the coronary side effects are lowest with the surgical orchiectomy. Whereas if you see medical GnRH analogs are there, antagonists are there. Antagonist, the cardiac risk is slightly less when compared to analogs, more or less same. But antagonist is, if you take the injection thing, we have to take it monthly, whereas agonist, we can give it 3 monthly or 6 monthly. Luckily now, tablet form, syrup forms are also available in the antagonist form. So, but if the patient misses the pill, then that is the problem. So this is about the surgical and medical orchiectomy. So intra findings were there. Coming to the HPE, same adenocarcinoma, bilateral orchiectomy, testis was normal. Then, so coming to the any prostate cancer, which is metastatic, we have to divide into whether it is high volume, high risk, or low volume, high risk, or both volume and risk we have to assess. So unfortunately, in India, most of the patients are high volume and high burden. We rarely see low volume, low burden diseases. So most of the cases in India are high volume, high burden diseases. And the problem with the prostate cancer is we have to make the prostate cancer as much as in the hormone sensitive part only. Once the patient turns into castration resistant or hormone resistant, then it will be the lifespan will be short. then morbidity will be more. So because most common site of prostatic cancer mets is vertebra. So any vertebra collapse, compression, there can be severe paraparesis, which can cause severe morbidity to the patient. Sometimes if there is delay, there can be complete irreversible paraparesis can be there, which can involve bowel or bladder involvement. So that risk is the problem with the prostate cancer. And so my patient was hormone sensitive prostate cancer, which has spread to bones and nodes. It is a high volume, high risk disease. Luckily, patient had ECHS. So I am fortunate I have started on the Arison's protocol. Triplet I have started. So along with that, gadolinium PET CT was done. So gadolinium PET CT, same, it showed concordance with the all the MRI and bone scan. So multiple bone mets were there, and PSA was 1680. So after a time span of 4 months, then I have done PSMA PET CT and PSA. So one thing is, once we see prostate cancer patient, they will feel very happy once their PSA goes down. So that is why this is the only cancer, and this is the in this cancer only in the trials, PSA is also reduction in the PSA is taken as a one of the endpoint, and and PSA doubling time is also important. So not only tumor marker, it gives us prognostication, prediction, and also accurately we can follow the disease. And whenever there is a clinical disease progression and PSA is normal, then we have to think of neuroendocrine transformation. So this is a clinical pulse. So whenever there is liver mets, extensive liver mets, extensive visceral mets, PSA is in the normal range, and patient is deteriorating, then we have to suspect neuroendocrine transformation. So PSA was 0.9, and so planned one more cycle of chemo, and 6 cycles I have given. So, but patient received 8 cycles. Then I did PSMA PET CT. It was more or less stable. PSA was slightly increased. Then I kept on same treatment, darolutamide and this 6 monthly bone modifying agent. So important thing in the about the bone modifying agent in the hormone sensitive prostate cancer is we no need to give 21 days, once in 21 days or once in monthly. We have to give only osteoporotic dose. So in the hormone sensitive prostate cancer, we no need to give monthly doses. We can use 6 monthly dose, and this is the most important thing. And along with that, we have to know the testicular suppression or testosterone suppression side effects also. Patient will have psychological side effects. Patient will have peripheral thinning of limbs, centripetal distribution of fat, mood changes, and slight increased risk in the CAD. So these all we have to keep in mind along with the disease management. Then his PSA went to 955. So but PSMA scan showed nowhere else the disease, only the prostate gland has shown up the bed. So that's why we have given only RT to the local side. Then still patient is going on, and then we have continued same darolutamide and bone modifying agent only. We did not add. Luckily, we got very good PFS. And the beauty about the darolutamide, as explained by the previous speakers, it is one of the, we can say, one of the best drug in the prostate cancer, and it is evolving. First, it has come into the non-metastatic castration-resistant prostate cancer. Then now, metastatic hormone-sensitive prostate cancer, approved with the triplet, now approved with the doublet also. So, and definitely it can be combined with PARP inhibitor, and it has very less or least drug-drug interactions, which is most important. And also, it does not enter into the brain, so there are no CNS side effects. These are the two most important, because whenever we treat a geriatric patient, we have to check the drug list. So drug list is most important, because so for diabetes, hypertension, thyroid, and multiple problems will be there. They can be minimum 5 to 10 drugs. So we have to see all the drug-drug interactions. And we all know the side effects of abiraterone and enzalutamide. So abiraterone is highly toxic drug, though it is cheap, highly toxic drug. So we have to monitor the weight, we have to monitor the blood pressure, we have to monitor the potassium, drug interactions, we have to give with steroids. So these are the problems with the abiraterone. triplet. So with docetaxel abiraterone is the only drug which is approved with the triplet when compared to the darolutamide. Unfortunately, triplet enzalutamide did not show benefit. So if you want to choose triplet, then only two regimens, that is peace protocol or this Arisans, we have to choose. Except cost, I think there are no other issues with the darolutamide. So only cost is the a little high. So that is the issue. But when compared to the efficacy, even the overall survival benefit is also more progression-free survival, castration-resistant-free survival. So all are better with the darolutamide. And prostate cancer is a variable cancer. In some, it will behave like completely indolent. In some, it will be very aggressive. And at diagnosis only now we are doing BRCA testing, HRR testing, and in desperate situation we are doing MSI and HER2 also. But BRCA and HRR are must. And definitely, I think darolutamide will be approved in the in all setting. It will come. Now it is not approved in the locally advanced setting where abiraterone is approved. So in that setting also definitely I think darolutamide will come. So, and whenever we see prostate cancer, along with disease, we should not forget to do the comprehensive geriatric assessment. That is most important, and quality of life, which is most important. And definitely, as our patients are high risk and high volume, I prefer triplet because conversion of sensitive to castration resistant, definitely our morbidity will increase, patient's morbidity will increase, and even our morbidity and mortality will also increase. And we should not restrict a good drug for a rainy day. In any cancer, we should use the best drug in the first line as early as possible. So this is about my case. And luckily, patient had good benefit and there were no side effects. It was completely patient did not tell any side effects with this one darolutamide. And we no need to monitor about the electrolytes also. Unlike the abiraterone, we have to monitor blood pressure, steroid side effects, we have to see weight gain side effects, and electrolytes monitoring. This is not there with the darolutamide, and with enzalutamide, it is not approved with the triplet. Doublet only we can use, and enzalutamide we know it can cause CNS side effects, convulsions, it can cause hypertension. So along with the docetaxel, these problems, it will be very tough. Darolutamide will be my choice in the first line in any setting, whether it is non-metastatic castration resistant or hormone sensitive prostate cancer. If you want to give doublet, so sometimes patient has high risk and high volume, docetaxel can be ineligible. So patients want sometimes patient or relatives want chemo-free regime. So in that setting, better to give doublet, that is GnRH analog along with darolutamide, which is a good combination. Chemo side effects can be chemo-free regime we can give. If the patient accepts, then we can add with the chemotherapy. And like breast cancer, when there is local progression, we no need to change the treatment. Just we have to add the local therapy, whether it can be any form of radiation or rarely it can be surgery. When there is only overt systemic progression, then only usually I change the treatment because we have to reserve the treatment options. And when the patient is responding well, definitely we can give local RT and we can proceed. So this is about my case. Anything to discuss?
Thank you, Dr. Sanath. As both of you have said, darolutamide is a good drug with very minimal side effects, side effect profile, especially as Dr. Sanath has pointed out, in the context of polypharmacy in the geriatric patients. It is always important to note that having least drug interactions and having better side effect profile is very important. So a few questions. I will start sharing my screen. Is it visible?
Yes, sir. Visible, sir.
So Dr. Shravan, are you there?
Yes, sir, I'm this.
Yeah. So, which patient, in which type of patients will your clinical decision sitting in the clinic will probably drive you towards intensification of therapy, either a doublet or a triplet. Anyway, single agent is only ADT is not a standard of care anymore. Probably addition of a doublet or triplet is what is required. So, which patient characteristics would you look at before taking a clinical decision?
So, two things, sir. One is patient-related factors. Second is tumor-related factors. Disease-related factors. So, in a patient who is, though we know that patient prostate cancer is a disease of elderly, those who are elderly, but with a good ECOG performance status, not much of frailty, and not having comorbidities. So, these are the main patient-related factors I do choose. And with respect to the disease-related factors, yes, patient who is especially having visceral metastasis, high volume disease burden, symptomatic for the disease. So these are the patients where I have the good population, good patient characteristics, along with the high risk features in the with respect to the disease. So these are the patients I tend to err towards giving a triplet regimen where I can improve the progression-free survival, and so that we can delay the or we can delay the progression to the metastatic CRPC setting. So that is what more important in managing these patients, as much as possible delay from HSPC to CRPC. So I would judge based on these factors.
Yes,
And of course, as
in
said,
all the trials,
comprehensive geriatric assessment also plays a vital role in choosing.
see, in all the trials where the triplet therapy was given, the ECOG performance status was either 0 or 1. So it is most important to identify these type of patients rather than just thinking high volume, high risk disease should go for triplet therapy. So selecting a patient is very important. And as Dr. Sanath has told, polypharmacy and other CNS related concerns or cardiometabolic risks, probably the abiraterone or enzalutamide are not good options for patients who have this. And I practically have seen patients, even though they say that with enzalutamide the incidence of seizures is really less, probably around 3% to 3% to 6%. I've seen patients who develop new seizures on enzalutamide, and sitting in the clinic, you can see that the patients already devoid of testosterone. The levels of fatigue they face is extraordinary. Even what a good amount of counseling or exercise also probably will not help them. So in these situations, I think darolutamide will add a lot of value in treating patients safely. So the main thing, the if you go to the NCCN guidelines, in low volume disease especially where doublet therapy is approved, based upon the Aeronaut trial, NCCN has put darolutamide as category 2B. Shravan, do you think this is comparable to RPFS is comparable to other trials like the Titan and the Arches where there was OS benefit, and does that affect your treatment decision?
This is a bit tricky situation, but we don't want to do any cross trial comparison because each has its own,
Yes.
the patient profile and see endpoints, efficacy, or safety analysis. But we end up doing in routine practice because that's how we choose one agent over the other.
Mm.
So, this is a disease of chronicity. So it is not just, efficacy endpoints with respect to the just progression-free survival. So we need to navigate from HSPC to CRPC as much as possible. The quantum is paramount, of course, but the quality of life of the patient is also very, very important. It is not just the efficacy or delaying the progression to CRPC alone. So the hazard ratios may be slightly different with respect to the various studies, but what more important in driving or in choosing darolutamide over other agencies, as we have discussed, it has a least drug-drug interactions, least side effect profile of the abiraterone or enzalutamide related ARPIs. So of course, the side effect profile plays a vital role. Also, the drug-drug interactions.
Yes, thank you, Shravan. So, I will close this with probably a take-home message of saying that ADT backbone is essential in treating metastatic hormone-sensitive prostate cancer. It should be the backbone, but treating the patients with ADT alone is obsolete. So, and probably I would prefer ARPA doublets are a standard. In most of the patients these days, we start them with a doublet treatment. We have moved out from prescribing docetaxel with ADT alone because of the volume, because strict definitions of volume of disease and risk of disease have come, and probably in a high volume disease, either patient is a high risk or low risk. High volume disease mandates triplet combination therapy if the patient is fit. That should be the prime criteria. As Dr. Sanath has told, geriatric assessment, frailty assessment should be of prime criteria in the outpatient clinic. So I would thank Bayer and Sandeep for providing this opportunity in having a great discussion about management of metastatic hormone sensitive prostate cancer. Thank you.
Thank you, Dr. Yugandhar Sharma, sir. Sir, before we close, let me check the chat box if any questions are there.
Yeah.
So, sir, I don't see any questions in the chat box. So, thank you, Dr. Yugandhar Sharma, sir. Also, Dr. Shravan, sir, and Dr. Sanath, sir, for your taking your valuable time. So, with this, we can conclude the session. Thank you, sir. Good night.
Thank you.
Thank you, sir.
Thank you all.
Thank you, Bayer, for this
Technical
opportunity.
team, we can close the session.
Yes, sir, we are concluding the session now.
Thank you.